in other words, it's not simply just the baby, it's not just the pelvis. I think the other thing is how you are mentally and emotionally able to cope with labor is a factor that is significant. So let me put this in terms that you understand. You can do all this work ahead of time, but on the day of the big day, if you are very stressed, sleep deprived, anxious, and things don't go according to plan, it causes things to be very difficult to cope with. Does that sound like anything you've had a recent experience with, perhaps? So, the same is true with this. So there's lots of terminology here. I think that is something that I would be very tuned into. For example, there's a difference between the phases of labor and the stages of labor. So you need to know what those differences are. All of the phases occur in stage 1. Yes?
Mm-hmm.
Okay. So let's talk about the passageway first. So we talked about the baby. We talked about the shape of mom's pelvis and how that can impact the position that the baby gets into the pelvis. And so one of the key landmarks here is the ischial spines, and that's going to be my landmark for what criteria?
Station.
Station. And station is expressed in negative numbers, 0, and then positive numbers. Okay. And we talked about how this is the false pelvis, but the true pelvis is lower. So it's really this opening, and then we mentioned the diagonal conjugate and the obstetrical conjugate. And the obstetrical conjugate is actually estimated, we subtract about 1.5 centimeters away from the diagonal conjugate. And so if you note in the records that it says diagonal conjugate not reached, that is not a risk factor. That's actually a good thing. Now that is talking about the pelvis. Now let's talk about the cervix. So if there's been any history in her past about cervical biopsy, if there's been trauma, if she's had a lot of repeated procedures like D&C, that manual opening of the cervix can sometimes cause trauma. So the cervix, it can sclerose, meaning it gets harder, but it can also get floppier and be easier to open. So it's not if this, then that. It depends, okay? But certainly I would want to know if a patient had a bunch of procedures done that she may have more difficulty with her cervix opening and dilating. So dilation is in numbers. We usually go 0 to 10. 0's closed, so you may not hear 0, you may just hear closed. And the effacement's in a percent, so it's 0 to 100%. So when we say 100%, that means paper thin. And so when we say paper thin, this is what we mean by paper thin. So if you put your fingers in, you barely feel anything there. So it's really easy to miss when you do a badge exam because it's so thin that, nurses will check and they're like, I don't feel anything at all, but it's that little lip of cervix that's there, okay? Now, generally, not always, but generally, dilation and effacement go together. So let me give you an example of what would be expected or normal. So the patient is 5 centimeters dilated. Her effacement's probably going to be 75 to 100%. Okay, we don't see people who are dilated 9 centimeters but efface 25%. That doesn't make any sense logically. Now a multip could be 6 and 75 or 8 and 80% or something like that. The other thing you got to remember is sometimes what happens is there's edema on the cervix with a prolonged labor. So let's say she had been 100% and the cervix is starting to feel thicker. It's because there's been so much contractions in the baby's head up against the cervix, and a lot of times the baby's head is too big for mom's pelvis, and so there's edema that occurs there. So that thickness returns, that's not a good sign. Okay. Generally, when it comes to vaginal exams, moms want forward progress, so we tend to be conservative. Because I would be very fussy if nurse number 1 said I'm 4 and 75, and then 2 hours later a nurse comes behind me and says, nope, you're 3 and 50. I'm going the wrong way, okay? And that's one of the reasons why, as a new labor and delivery nurse, you often will have your preceptor check behind you, and you kind of learn, because it's not something you can see, but I think, again, it's getting your kind of judgment there. And you'll learn, there are some physicians and midwives and things, they might be generous. Some are a little bit more conservative. I know for me, I was always more conservative because because I did not want a physician to come in and make my patient go backwards. The key thing is I do think it's best to have the same person do this exams because again, you're able to make the judgment from point A to point B. We do far fewer vaginal exams than we used to. So you may see things in the book or in old review books where it talks about doing vaginal exams every 2 hours. We don't necessarily do that anymore because there's not really a need to do it. Now in the vagina, remember that we have a very vascular, stretchy, muscular area there. We see, again, the loss of the mucus plug, and this is also, because it's so vascular there and the forces of labor and the baby pushing up against the cervix, that's what makes the bloody show. So it's kind of the mucus plug, but it's kind of tinged with some of that bloody mucus. So it's not bright red blood that comes out of the vagina. But this will, again, distend, and it's better if it has time to do this to accommodate the baby. When we have people who are like a freight train and they have a precipitous labor, the baby comes very rapidly down the vagina, and the vagina doesn't have time to stretch and accommodate, and so what happens is that mom can tear along the vaginal wall as the baby's coming out so rapidly. That's also the reason why we don't really like babies to come out with multiple presentation. If the baby's in the correct position, the way things are supposed to be, it tends to be pretty smooth and there's not a lot of trauma. But if there's a complication there, then that can pose more trauma to mom. All right, so in looking at the passenger, my folks who got to see babies yesterday got to feel some fontanelles. Yeah. So again, I would describe newborn babies' fontanelles as soft and flat. I would not describe them as depressed. So just some weird, wonky vocabulary in healthcare. A depressed fontanelle is usually a sign of something much more serious, could be a sign of dehydration and things like that. But in brand new babies, it's not bulging and there's a little indentation. It's pretty easy to feel, particularly the anterior fontanelle. What I recommend for my students is if you've got an anterior fontanelle and then just take your fingers to kind of get back to the posterior fontanelle. Sometimes the posterior fontanelle is a little bit difficult to palpate if there's a lot of caput and swelling there on the scalp. But in looking at this, you have the anterior fontanelle, which is diamond shaped. You have the posterior fontanelle, which is triangle shaped. But what happens in terms of the baby is that all of these spaces between the bones of the skull allow for the shaping of the baby through the birth canal. And so that's how we get molding, that's how we get caput. And in some cases, we can get a cephalohematoma because of the trauma. So for example, let's say that, because again, when you're doing a vag exam, you're not actually feeling the anterior fontanelle, you're feeling the posterior fontanelle. Because the anterior, the baby's head is flexed like this. So when you do a vag exam, you're kind of feeling this part of the head, not this part of the head. If you're feeling this part of the head, the baby has a brow presentation, which is not ideal. Like this is mom's pelvis, okay? But again, in terms of if you had forceps or things alongside the baby's head, that trauma there is what puts you at risk for things like cephalohematoma. If you have a vacuum on the baby's head. Did anybody have a C-section yesterday? They had a vacuum. So a vacuum is not just for vaginal deliveries. Some providers use the vacuum for C-section to assist in having a controlled management of the baby's head and get them out. How big was that baby? Do you remember?
7 pounds.
Not real big. Okay. So again, that's just kind of showing you some different aspects of the baby's head. Looks a little different than our head. And so in terms of station, when the baby is floating or the baby's ballotable, then remember it bounces off my fingers, and that means we do not have engagement. So what might be some potential complications if I don't have engagement in the pelvis? Well, usually, if I'm here at this point, the head is there, but I'm not engaged, but maybe I come down here and I, again, get in the wrong position. So presentation and position are not exactly the same thing. So in talking about the baby not being head down, that usually what happens is most babies, they start to get head down as we get closer to 36 weeks, because remember, it's cramped in the apartment because you want to get out of the balloon. And so you're usually here, but just because you're head down doesn't mean you're in the right position. And so again, what should happen is the chin needs to be tucked down like this. You're in this fetal position. I don't want to be like this. I don't want to be straight on. I don't want to be off to the side. If my head gets in the pelvis kind of off to the side, again, it's going to be really hard to deliver vaginally. All right, some terms. These are need-to-know terms, okay? And we're going to practice with this. This is one of the things that I think, I'm not a huge fan of like Quizlet, but I think this would be the type of thing I would make a Quizlet for, okay? So attitude, lie, presentation is what we're going to start with. So attitude is the relationship of fetal body parts to one another. 99% of the time, the attitude is flexion, okay? And so what this means is that all the parts of the baby are in that fetal, everything is flexed together, okay? Now, what's the other alternative? We'll talk about parts being extended. So let's say you have a single footling breech. So you have one foot coming through the cervix. So in that case, the attitude is you would actually indicate, upper extremities flexed, lower extremity extended, okay? But 99% of the time, flexion is how you describe attitude, okay? Lie has to refer to the baby in relation to maternal spine, okay? The vast majority of our babies are going to have a longitudinal lie, longitudinal. So again, like half of your question, flexion and longitudinal. Okay, the other options are transverse. Oblique means it moves around, so it doesn't stay in the same spot. But the vast majority are longitudinal. So in terms of the presentation of the baby, we have cephalic, and so sometimes you'll see cephalic and vertex used interchangeably. So did you hear those terms, or, because again, we sometimes are a little bit sloppy in labor and delivery with our language. Most of our babies are cephalic and vertex. Excuse me, cephalic means head first. So you can have syncopute, brow, and face. Syncopute is like a chin presentation. So they're just alterations in what's coming out as the presenting part. That's all that means. For breech, complete breech, it means that the baby's flexed, but the butt's coming first. Anybody have a breech baby yesterday? I didn't hear about any breech from a lot of times in the nursery, you can kind of tell breech babies in the nursery, they lay a little bit differently than a vertex baby. Frank breech for my swimmers, they are in the pike position. So their legs are extended like this. So they're still bottom first, but their legs are extended. And then footling, you can be a single footling or you can be a double footling. My experience with double footlings has been with preterm and a high risk of prolapsed cord because the umbilical cord is right between their legs. So as their legs come out, they pull the cord and it's an OB emergency. And then the last one is a shoulder presentation, which again, it's like the little nubbin of the acromion process, just kind of right there. And again, it's a mount presentation. So if you have to choose, you're a mom, you want your baby to be flexed, longitudinal, and vertex. All right, this is the part that is a little bit confusing, so tune in here, okay? So this is mom's pelvis, this is the baby. So we're talking about position, which is in addition to presentation, okay? Everything you see here is in the book, okay? And so what we're gonna do is, first you have to think about is the presenting part on the right or the left side of maternal pelvis. This is the right, this is the left. This is the baby's head, okay? So the presenting part here is on the right side of mom's pelvis. The O, the occiput, is the middle part. And then the last part is it facing anteriorly or posteriorly. So this baby right now, everybody see my baby, is ROA, right occiput. The occiput is anterior. It is not where the baby is looking. It is where that presenting part is on mom's pelvis, okay? So this is ROA. This is ROT, right occiput, but it's transverse. This is right occiput posterior, ROP. So this is what I would consider OP. This is what I would consider OA. Most of our babies deliver OA. We want you to be OA. Left occiput, anterior, posterior. Posterior. LOT, left occiput transverse. LOA, left occiput anterior. Okay? So we like OA. Like, I'm not real particular if it's LOA or ROA. I like OA, occiput anterior. OP can be delivered vaginally, but when moms have a baby that is occiput posterior, a lot more back pain. The hardest part of the baby's head is pushing up against her spine. Labor can be longer. She may have to push longer. And again, there's more trauma that can be there because the baby doesn't always kind of come out in the right position, and so you can see some more tears. She might need an intervention, so she might need an episiotomy, she might need forcep or vacuum. And sometimes what will happen is the baby might start OP, and then as we get through labor, the baby turns to OA, and then all of a sudden, when the baby turns to OA, smooth sailing. Okay. So I don't want you to think OP is horrible, but there are some women who have a kind of a failure to progress in labor, and it has to do with the position of the baby. So what do we do to help the position of the baby? What helps get your baby in the right position? Moving them around. Anybody see a peanut ball yesterday? All right, homework for next week. Talk to your clinical instructors about peanut balls, okay? Or birthing balls. So we have birthing balls, like the exercise balls, people sit on and they rotate their hips. That's often used for pain and comfort. We have a peanut ball that we put between a patient's legs, and it actually kind of widens the pelvis, so it helps the baby rotate around through the pelvis. Very common. Nursing intervention, it's independent. I don't need a physician's order to use a peanut ball. But you have to remember, for what helps birth a lot is mobility. So how many of your patients were up walking around yesterday? In labor. In labor and delivery, how many of your patients, anybody have a patient who did not deliver with anesthesia?
She just came in and
She had her baby.
had her baby in 10 minutes.
But she was probably mobile at home.
Yeah.
We did not hook her up in bed. We didn't hook her up to a bunch of cables. We didn't start an IV on her. We didn't tie her down. So the more ambulatory, the more mobile you can be, the better. Because again, you're in an upright position, labor's working with gravity, pushes the baby down against the cervix. That's gonna help labor be successful. All right, so let's talk about the forces of labor. You have involuntary and voluntary. So primary, I don't have to think about contractions, they will just occur. And they, again, occur, you have some preliminary contractions. So that Braxton Hicks contraction doesn't really do much in terms of cervical effacement and dilatation, but it's kind of prepping the uterus for the work ahead. It's really important when women start having contractions that they need to, again, let the muscle do its work, but it is uncomfortable, and again, it has irregularity to it. So you may have a woman who has a bout of contractions at 37 or 38 weeks, and they stop. So for example, you might have a patient who at 36 weeks, she was closed, long, and high. Cervix was closed, effaced, very long cervix, baby was very high. Maybe she had a day where she had some contractions. They weren't that uncomfortable for her, but it was like, gosh, I'm having contractions like every 10 minutes. I noticed I had some bloody show. So she goes back the next week, and now she is 1 in 25%. So she's had some cervical change. Do we want her to go to the hospital? No, because she might be 1 in 25 for another couple of weeks. Okay, so those kind of preliminary contractions are good, they're helpful, okay? But we have to kind of watch for that kind of click over into labor, okay? Now, secondary, this is where mom has to help out. Mom needs to push and push effectively. So all of my folks who pushed with their patient yesterday, raise your hand. How was your pusher?
The pusher, what do you mean, like?
The patient.
The patient, we had a few, but one of them was like really blown out, like the nurse told me she was blowing out too much air, and that was like affecting like how she was able to bear down.
Okay.
And then there was like one that she pushed like one time, baby shot right out.
Okay, was that your all's baby? Did you all deliver?
Here we
Your
go.
8 centimeter patient?
I don't even know if she really pushed, I'm
She
sure
maybe
she
just
did,
came
but that
out.
just, baby just.
Yeah,
Yeah.
the contractions, there wasn't much voluntary
She didn't
force
push
there.
at all.
Because the thing you have to realize too, I'm assuming it was not her first baby.
No,
Eight.
it was her.
So as soon as did they put her up in stirrups or put her
No.
legs
No,
back?
they didn't have enough time.
Because sometimes when you do that, child, it
She
just
had a
comes.
pillow leg, she had one leg up a little bit, but just a pillow
Yeah,
leg, right,
yeah.
and that was it, but she had pneumonia.
So the other thing is, do women have to deliver in bed?
No.
No. So again, she didn't necessarily have to deliver in bed. What about your patient? Mike? Did she push?
I thought, yeah,
She was pushing for.
she was pushing for like 20 minutes.
What do you think about that?
She pushed for 2 hours for her first.
Ah, so that was a big improvement over the first
So
one.
she was like really excited.
I bet she was.
was.
Woo, woo. Yes, back in, old-timey days, we would push with patients 2 and 3. I look back on that, and I'm like, why in the world did we ever do that? It was just horrible. Like, I would leave and go on my lunch break, and the tech would push with the patient, and then we come, I mean, the poor woman would be exhausted. And so we finally did some research and determined, hey, guess what? We're making them all hypoxic, and we're putting our babies in distress, plus we're increasing the risk of infection by having moms push for 3 hours. It's really not a good idea. So you labor down. And so laboring down is involuntary, pushing is voluntary. You guys know what I mean by the term laboring down? So she's completely dilated. In other words, the cervix is not there. But we're letting the contractions bring the baby down, labor down, to help the baby be in a positive station. It's better to start pushing from a positive station than 0 station. So let's say you're complete dilated. If you're completely dilated, do you have any effacement? There's nothing there, it's 100% effaced, because there's no cervix there. There's no cervix around the baby's head. So our little balloon, the balloon is gone. All I feel is the baby's head. But I still let contractions help kind of push the baby down lower in the pelvis so that mom will not have to push as long. So we talked about breath control with pushing. When you tell patients to push, it's really important that they bear down very low. It's like a bowel movement type push. It should not, the air should not be up in the lungs. It's not a thoracic push. Some people push with their arms, and it's like, nope, I don't need you to push up here. And it's almost when patients are pushing, you're gonna have them bring their legs back, and their bottom is almost like pointing up towards the sky. So it's not like a straight down push, it's kind of pushing, because you gotta get the baby around that symphysis pubis and then be able to come through. So it's, again, it's almost kind of a circle type movement. All right, so let's talk about contractions. Did you guys get to see, my labor delivery folks see some fetal monitoring? So you'll notice in real life, those contractions are not pretty. Like, they're not as pretty as what we show you up here and what you see. There's a lot of garbage. And it's like, what's that? Oh my gosh. And so you really need some help from your clinical instructor to say, that looks like a good labor pattern, that's just garbage. Even though that looks like a good labor pattern, it's not. You need some help in guiding with that. So just some terminology. With the contractions, We talk about the increment, the acme, and the decrement. And the reason why this is important is because we have to evaluate our decelerations. Intensity is determined by palpation with an external monitor. So an external monitor, also known as a TOCO, is only going to be measuring frequency and duration. It does not measure intensity. An intrauterine pressure catheter is going to measure frequency, duration, and intensity, and resting tone. Okay, anybody have IEPC yesterday? So do you know why your patient had it?
They broke the bag of water and then the baby immediately started having
D-cells, okay.
They
And
did amnio infusion.
okay. So the amnio infusion is putting fluid back around to alleviate the cord compression, and you only can do that with the IUPC. You can't just randomly put fluid in the uterus, back in the uterus. Were they measuring her contractions okay with the external monitor, or not so much?
It was okay, but she
Yeah.
needed to be on her side, and so it made it harder to measure
Okay,
with her.
because that's another thing, an IUPC gives us precise measurement. So I think as a nurse, one of the things that I would wanna know is if I can't accurately measure contractions with the TOCO, I'm gonna do the easiest thing first. The easiest thing first is to reposition the TOCO. Because the IUPC, while it's great, it is invasive and the water needs to be broken. And once the water's broken, we're committed to delivery, right? You can't send somebody home with the water broken. Their term. So frequency refers to the time from the beginning of the first contraction to the beginning of the second contraction. So let me give you some examples here. Everybody got your save the dates from Professor Bone? She said it super fast and it went with some sections, so I just wrote it down correctly, so. Okay. So you have a patient and they're writing down contractions. So we have somebody who's at So in other words, you have a patient, they write when a contraction starts. So this contraction started at 7:08. So this is a pattern that would make you think more of being in active labor. This is a pattern where you would say, I'm not quite, maybe early phase, latent phase. But if you look, this is 7 to 8, 9, 10. Pretty far apart, really. Versus here, I've got 2, 6, 5, 5. So about 2 to 6, 2 to 5 minutes apart. This provides a better example of a labor pattern, okay? So what do people do wrong? They time them incorrectly. So they sometimes measure the time from when the contraction ends to the contraction, the next one, so they make the contraction seem really close together, and it's not. We always want to time from the beginning of one contraction to the beginning of the next contraction. That is frequency. The duration is from the beginning of the contraction to the end of the same contraction. So how long that should be. Duration is reflected in seconds. Frequency is reflected in minutes, okay? And you'll notice, again, it's not clean, it's not pretty. You know, a lot of people say every 5 minutes. Well, life doesn't work that way. It's messy. So it can be 2 to 5 minutes, 2 to 4 minutes, so it's approximate. The same thing for duration. Does it make a big difference for you as a nurse if it's 60 seconds or 70 seconds? Do you think that's a big difference in contraction duration? It is not. Now, there is a big difference between 60 seconds and 120 seconds. You should not be having a contraction that lasts 2 minutes. That is too long, your baby's gonna go into fetal distress, okay? So that's frequency and that's duration. Intensity, did you all talk about mild, moderate, strong? So when you palpate the uterus, they start out as mild, then they get moderate, so they get a little bit more firm, but still a little bit of give here, and then they get strong. Very kind of subjective, because some people, when you palpate the uterus, they feel strong, but they're smiling and they're talking and they're, chatting with their friends. Other people, Okay, so you have to look at how the clinical manifestations of the patient match up with the palpation of the uterus. So mild, moderate, and strong. With an IUPC, we do millimeters of mercury. So we talk about the height. So the height of the hill on the monitor actually matters. So Emily, do you remember, did you have criteria that you were trying to achieve for your IUPC within 10 minutes? Was it somewhere like 210, 220, something like that?
They didn't have criteria. It was her 8th child, so
Ah.
they just wanted
To
at
watch.
that point, they just needed an IUPC because the D cells and she was already like smaller.
Gotcha.
The baby was measured smaller,
Gotcha.
so they just were trying to get that.
So sometimes what they'll do is, and every facility is a little bit different in terms of their criteria, but you measure from resting tone to the acme of the contraction. The resting tone is usually somewhere in the neighborhood of 10 to 20 millimeters, so you're not starting from 0. So for example, if your resting tone is at 10 and the contraction goes up to 50, so that particular contraction is 40, because you start from the base and then you measure to the acme. And so we might have to adjust so that we get at least, and they're called Montevideo units. We have to get so many Montevideo units in a certain timeline. And so the nurses will kind of measure, and that's how they'll know Mapitocin is fine, Mapitocin needs to go up, needs to go down. Okay? Do not worry about Montevideo units. That is something you do not need to worry about. All right, let's take a break. We're at 20 after 1.